Well, good afternoon all. Thank you very much for giving up your time to join this webinar. So this webinar is going to be shining a light on Mid and South Essex and their approach to implementing effectively a system-wide approach to falls. Today we're going to be, as I said, hearing about Mid and South Essex and all the great work that they've been doing on the in response to falls. If you've never come across fail gains before, which I'm sure majority of you who have joined the call have, just as a bit of background, fail gains is all about eliminating ambulance call-outs to non-injury falls. That's what we stand for. That's what we're working towards. It's a you might call a big, hairy, audacious goal, but we're prepared to take every step that we can to mitigate the problem that falls cause across the system. And indeed nationally. So we're going to be going over the problem, how the project has been implemented, and subsequently the results, first in the care home world, and then moving on to urgent community response, and then from a primary care network area as well. So it's going to be a jam-packed webinar. We've got a presenter from each of those individual areas, talking about how they've implemented it. So without further ado, we're going to make a start. First of all, as I said, going over the problem. One other thing I just wanted to say is there is a slight possibility that this webinar may extend longer than we anticipated. So there is a recording available. If you need to leave any point throughout, then you're welcome to do so, and we'll circulate the recording afterwards. In terms of questions throughout the session, then there is a Q&A box up on the top right. So feel free to pop your questions in there. And then at the end of the session, we're going to go through those and ideally answer them one by one, but we may have to consider time restraints as well. So Angela, you are up next. I will introduce you. So this is Angela Harding. Angela's going to be giving us an overview of the problem around falls and the impact of long lies.
Thank you, Grant. Thank you, everyone, for attending today, and I hope you get lots of good benefit from the webinar. So I've been asked to basically bring you up to speed with what the problem was and how the actual project came about, which Michelle will then go on to talk about. So what we know is that obviously falls are quite a large problem for us in care homes, and that as ambulance availability, ambulance waits was increasing, falls were obviously not being rated as a priority, along with things like heart attacks and strokes and things like that. So what we identify is that, you know, the residents are potentially looking at long lies on the floor. We're looking at the distress that causes for residents. It can be quite scary for the residents and also for carers, because it is quite distressing for carers to see their residents on the floor, possibly in pain, possibly not having the availability of fluids and diet and things like that, and pain relief. So it's important that we recognise that, but also the fact that during these long lies, the condition of the resident could be deteriorating. So one of the things that we wanted to do was see how can we make this period of time waiting for an ambulance or conveyance to hospital, what can we do to try and resolve some of those issues? So what happened was that there was one of the OTs looked at lifting equipment, lifting chairs, and to see what sort of chair would help with reducing those long lies and also benefiting the residents, so that that actually could be more comfortable and that the carers would be able to care for this resident during that time. We know that hoisting is quite distressing for some residents as well. There's also the issue of dignity. So hoisting, although that was generally a way of which we could look at moving and handling and relieving that resident during a fall, what we recognised was that actually that isn't necessarily always the best way. So we looked at alternatives. The razor chair was the one that was chosen as part of the pilot project, which Michelle will talk to you about in a moment. But the feedback that we got about the razor chair from residents, from carers and relatives was that actually it was much more dignified, the way in which the razor chair was used. It was easier and quicker to access, and sometimes in probably challenging spaces, challenging situations, the razor chair is a much better tool than a hoist. So the benefits of that are that we were able to reduce the long lie, able to reduce some of the deteriorating conditions, and actually make our residents more comfortable and, you know, the benefit of dignity. The using of the razor chair, what is important is that we also use an interactive post-fall assessment tool prior to using the razor chair. And the way in which we can do that is, for those of you that have the Wizan toolkit, there is an assessment tool available to you in there so that you can look at using a razor chair or the tool safely. So that's a little bit about the problem. So I'm going to pass you over to Michelle Angel now, who's going to talk to you about the project, how it came about and the outcomes for that.
As Angela mentioned, this is a system-wide falls pilot that we undertook to try and ease the pressures on our system, which is unprecedented at the moment and has been for some time. So the pilot involved 81 razor chairs going out across the system. We've had these in secondary care wards, our urgent care response teams, which we will present later on, and within our care homes. And so we've gone out across the system, secondary care, urgent care teams and care homes. We asked care homes for their interest in this. So before obviously sending anything out, we created a MOU with the care homes, and part of that was to agree to monitor the outcomes of this pilot. A key part of this pilot was an interactive post-falls assessment tool, which, as Angela mentioned, we've given the care homes digital tablets. So each care home has a digital tablet where this app is loaded onto it. In addition to that, if they have the Wizan equipment, that is also loaded on. And our care home training team, we're very fortunate to have an amazing care home training team, and they reference this app when they do with Wizan training for our care home staff. So in terms of the research that was undertaken, it was showing that 45% of fallers in care homes are uninjured and do not require transportation into hospital. So the above assumes that 55% do require an ambulance call out, and the cost of an ambulance is around £252. And you can see the quote from Leverland Lodge, one of our care homes, very pleased with using the lifting chair. It's just amazing, especially for our dementia residents. And this is something that's come through from most of our homes. And we had a really lovely bit of feedback from a member of next of kin who said that they'd seen their loved one picked up from the floor by being hoisted, and then saw a subsequent fall where they were picked up using the lifting chair. And the difference was incredible, and they felt so much more assured that this was now in place. So you can see from the pie chart there, this was a deep dive audit that the care homes agreed to participate in. So this was over 48 of those care homes, where they fed back each time that there was a fall, and Felgains provided us with this information, so they supported this audit. And of those, you can see 150 occasions the razor chair was used. And another quote there just emphasising that it's less distressing than the hoist. So in terms of results over that period of time, 244 falls would have caused 134 call-outs by comparison, it's 42 call-outs. It saved 92 call-outs, which equates to around £23,184. So you work it up, it's around 4,186 savings per care home per year. So it basically pays for the chair. As part of the implementation, partners were absolutely key. So as Angela mentioned, the OT provided the initial assessment on equipment, and we do have a different type of chair for heavier patients. You've got the secondary care involvement. They undertook a pilot in Southend Hospital, and then that's been upscaled to the other 2 hospitals within Mid and South Essex. The urgent community response team is incredibly powerful in the hands of these clinicians, and they're obviously going to talk through how they roll this out. Our local authority colleagues, so they supported in engaging with the care homes initially to see which ones would benefit the most. So we were looking at level of falls, but also for levels of engagement. And subsequently, Essex County Council has provided joint funding for additional chairs to roll this out further across Mid and South Essex. Obviously, the care homes participated in the audit and have also supported servicing. So the home needs to engage with Felgains to service the equipment on a yearly basis, and support from our EPUT training team, who reference the equipment, but also the falls assessment tool. Our ambulance trust have been fantastic as always, and we've informed their control teams where these chairs are, and obviously I think they've actually purchased some themselves now, but we're looking with Jamie Frayne about how PCN model can work. And then the private sector, so Solcom, who provide our telehealth equipment, have also worked with the provider of the falls post-assessment app and loaded it onto our Wizan tool for our care homes that have that. So our outcomes and values, so this is feedback that's come in. Staff and next of kin feedback, less distressing for the resident and loved one to be lifted with the razor chair. Workforce, 100% staff confirmed it's easier to utilise the razor chair as opposed to hoisting, and reduces the risk of manual handling injuries for staff. Time saved, 1 member of staff can lift with the razor chair as opposed to 3 hoisting the resident from the floor. Reduction of ambulance calls and A&E attendances, and reduction of sick leave due to back injury. So this is what's come back from the care home. So we've had quantitative and qualitative feedback from them. Efficiencies, as you've seen, we've only looked at the sort of potential call outs saved and not the potential reduction in admissions to hospital, because we've prevented deterioration of patient because they've been picked up earlier. That's the end of my presentation, so I will pass over to Mel Tucknott from Oakdale Care Home, who's going to tell you about her experiences.
Hi everyone. Yes. So basically, I was really excited when there was a knock on the door regarding this project, and the training was delivered, and I was really impressed by the size of it, and I was thinking, how are we going to use that to lift people up off the floor, because it was so small in a little bag. But so then we have a trainer at Oakdale, so she started to deliver the training at Oakdale to some of the staff. Obviously staff were a little bit skeptical at first, because, you know, for years and years we've always used hoists. They were a bit skeptical, but after a little play and going up and down everybody, and they started to feel a lot better about it and notice the differences of how easy it was to use, the time that it took, which give them more time, storage, because you know, our home is very small and we don't have much storage, but this fits nicely in a cabinet underneath the TV, so it is right in the hub of the home where we can grab it quickly if we need it. Yeah, it's I think about dignity, that's huge. You know, Angela touched on loads of stuff, especially people with dementia. Using a hoist, you know, can be scary for someone with dementia. They don't understand what's happening to them. We've actually tried the chair out on a few of the clients to get their feedback, some of them with dementia, and we had a lot of giggling going on, but they weren't stressed at all. And we have used it in 3 falls so far, 1 during the night, and 2 during the day, and it's worked very efficiently, and people have been safely put up to an upright position. It's all been recorded, and the feedback from the staff is really amazing. Like I said, hoists are huge pieces of equipment and they take a lot of time, and time isn't what you've got in a care home sometimes, especially if something happened during a meal time and all staff are supporting to feed people and the home is busy, and then all of a sudden someone's on the floor, you know, 2 carers, hoist, persuading the client, reassuring the client, getting them in it, and then doing it, you know, can sometimes be like 45 minutes. But now it's a lot quicker. You know, it can be done within 20 minutes. I'm really impressed by this project. I think it's going to be great for care homes. I've been in care for 40 odd years, so you know, things like this to make our jobs easier, to make sure our staff are competent, and the clients at the utmost front about the dignity is just amazing. I'm sort of loving the project, and hopefully it will push through. The money savings, I mean, I haven't seen figures and I've just seen them, are absolutely extraordinary how much money is being used, which could be used on other things. So that, you know, it's great, but I shall keep using it, and hopefully we'll move forward and it could be a thing of the future, which I think will be great. And it's a lot cheaper than a hoist for companies, because hoists can be a fortune and storing them. So yeah, all good. Thanks for asking me to share my experiences.
Thanks very much, Mel. That's good. It's good to hear it from the front line, so to speak. And I think what is being shared already around the dignity is important. And in terms of cost savings, I think Mel touched on it. Sorry, Michelle touched on it in terms of the cost savings, sure, in terms of the ambulance call outs. But when we start thinking about the long lives that we've prevented by a quick response and the subsequent saved admission, that's when really we start talking about cost savings and indeed time savings, putting ambulance hours back into the system. So thank you very much, Mel and Michelle, from the care home point of view. Hand over to Yvonne to discuss around the urgent community response.
Good afternoon, everyone. Thank you for joining us today. So my name's Yvonne Mabu. I am the Strategic Head of Service for the UCRT, supporting the teams across the MSE. So I'll be talking to you today about our journey so far and what we are doing to support the falls management within the MSE. So for those who don't know, the UCRT is an admission avoidance team. So we respond within 2 hours to the crisis needs of patients in their own homes, including nursing and residential care homes, to avoid hospital or need of new 24-hour care admission. In addition, we are now working as part of the virtual hospital in Mid and South Essex, meaning we can now accept referrals for patients with urgent or more complex health and care needs, as we are now supported by a frailty consultant. Our service has a range of specialists, including nurse practitioners, advanced nurse practitioners, senior assessors. We also have paramedics within the team, prescribers, support workers, physiotherapists, occupational therapists. We also have one of our teams who have social workers aligned to the team, and these colleagues will support the patient to remain in their home or place of residence during an episode of illness. The service covers 4 areas, so Basildon and Brentwood, Mid, Essex, Thurrock, Southend, Castle Point and Rochford. That's our inclusion and exclusion criteria. I believe Ruben will be sharing the slides for those who want to go through. So part of that includes falls, frailty and those who are vulnerable. So our journey so far for the UCRT in MSE, so we currently delivered by 3 community providers in the MSE Collaborative in the 4 places, as I mentioned before. So we started off as 4 existing rapid response services working under different names with different service specifications and brought together as one UCRT across Mid and South Essex back in 2019, where we started it as a pilot, looking at how can we provide a consistent offer around admission avoidance. So we had some teams, like I said, who have social workers aligned to the teams, some teams still doing some elements of the district nursing and planned care interventions. We had another team that provided a falls response, and they had back then a Munger lift, which is an inflatable device that you could assist patients off the floor. So building on to that consistent offer, we also started looking at what do we do around a consistent offer around falls management. And in 2020, we purchased our razor chairs, and we had 2 razor chairs in each locality to support our UCRT teams. And again, building on that consistent offer, once we started providing these services, raising awareness, we received feedback from partners and, service providers around accessing the service. So different localities have different numbers, different access points, etc. Especially it was useful feedback from paramedics who perhaps would work across the MSE localities, where if they were to go to Mid Essex and they come to Southend, it's different phone numbers. So we put in a business case and we did get funding. So we're now supported by a single point of access to ensure a consistent, standardized and equitable approach for all our residents in each place. Since early 2021, we've been focused on improved referrals and acceptance rates through an integrated approach. We also did receive some funds through the Aging Well Service Development Funds to include some occupational therapy and physiotherapy recruitment in each team to try and build again on that consistent offer. Some of our teams did not have therapies aligned to the teams. So I think this has also helped us greatly in terms of offering that holistic approach to patient management or response to falls, because you only not have a nurse or a support workers responding to falls. It could be a combination of a nurse or an OT or a nurse and a physio going out to assist patients off of the floor. So we've been doing a lot of collaborative working in MSE, so East and tech providers and 2 our UCR services in MSE are working hard to ensure appropriate patients who call 999 are redirected to the UCRT. So it means then you don't have to dispatch an ambulance. We're avoiding patients reaching that front door or subsequently being admitted to hospital and end up getting sucked into the system. So part of the work that we're doing with East and UCRT, so we realized or recognized we had to do some training or raise awareness for, partners and providers to understand what we do. So we did a lot of targeted engagement of East crews. So we had our UCRT staff going round the rat bays, each hospital site, doing lunch and learns with the paramedics on the ground, those waiting to hand over patients in A&E or on their lunch break at the ambulance hubs, etc., having discussions around UCR. Did you know about UCR? Did you know you could have handed over those patients? And on occasions, we did manage to turn around, 1 or 2 patients that we would have identified as suitable for the service. Development of custom training module for referring clinicians to raise awareness, understanding and confidence in the UCR. So we did some workshops and we had 100% of the feedback responses said they had learned something new about the UCRT's capabilities and were more likely to use it in the future. 8% of referrals to UCRT listed the pilot as the primary reason for their referral, and we have now an agreement that this training will form part of EAST's ECS training, which is their yearly update training, and consideration of inclusion for induction training for the new staff. So looking at the referral opportunities with EAST, we had quite a few work streams that we were doing. As you know, we were building on offering consistent offer, but we decided to focus mainly on push and pull model between EAST and UCR. So to support that, we have daily feedback loops with EAST leaderships where it's opportunities to pass on urgent comms, escalations, any risks, etc. We've now rolled out a preclinical triage SOP where it's easier to hand over calls quicker, especially where there's long ambulance waits. So calls can be passed directly to the UCRT single point of access preclinical triage in the East 999 control room. So the process involves a clinical lead in the East control room who will clinically validate the calls just to manage those risks and pass them directly to the UCRT SPA clinicians. So at the moment, this is done through daily touch points with EAST, and we're identifying suitable calls on the 99 stack. So this could be anything from C3s to C5s, but occasionally we have managed to turn around some C2 calls as well from the stack directly to the team. So we're seeing good numbers, especially through the daily touch points. I think on one occasion last week, we pulled about 9 patients in one sitting of a morning. So we've also got the hear and treat model, which we started back when we started doing the engagement with EAST, but this is more of the calls that would have had a clinical triage and then passed directly to the teams. We've also got clinical triage posts within UCRT. So this is a combination of paramedics recruited by UCRT and nurses who are senior clinical clinicians who work in the UCRT single point of access. They will rotate through the East control room and the IC24 call center as well, working on that pool model, pulling calls from the stack, triaging and signposting. So we now also have a falls desk. So this is a dedicated falls desk within East. Again, it's around that preclinical triage again, but this is mainly focusing around falls. This came after the 100-day challenge, and we realized there was some work to do around the management of falls, especially where East was in RIP 4 for quite a long time and the wait times for ambulances were staggering. So we decided to pilot at the beginning of the year a falls desk where falls would be passed directly to the teams, bypassing the UCRT SPA. Preclinical triaged falls that are passed directly to the teams. So the dedicated falls desk is mainly looking at calls who have this MPDS code 17004. So this is the code for the non-injurious falls. Some of the colleagues on the call have already alluded to some of the numerous benefits improving the patient experience and journey, the timely 2-hour response that UCRT offer, right treatment the first time. Like I said, we have an MDT approach to falls, so it could be a physio, OT, a nurse prescriber, whoever will have the right skill set to respond to that fall at the time. And ultimately, again, reduced ambulance attendance, reduced A&E attendance, and admission avoidance. So this is managed through East Falls desk in a push model. So senior clinician will clinically review the MPDS code 1704 prior to passing the calls directly to the teams. Like I said, it ensures long lines are welfare checked. So sometimes we have occasions where patients will need to be conveyed to hospital because they have an injury. So if we are unable to assist them off the floor and there are long ambulance wait times, we have supported East with welfare checks where we can go and see what can we do differently for the patient. Can we make them comfortable? Can we move them from where they are? Can we keep them warm, etc. In terms of data, so this is the data that we've got so far around the falls desk referrals. So from January to now, we've had 315 or just over of falls responses. So on average, a month you have about 30 or 40 referrals across the MSE for falls. So that is a staggering number. And obviously there's a lot of costs and benefits for the patients. So in terms of sustainability with East, so we're continuing to build on the work that we're doing between East and UCRT. So we've got fortnightly meetings between East and UCRT, so improvement cycle meeting with leads to review referral data using our dashboard. So we've now got a single source of truth. We've got a dashboard for UCR where we look at referral data, sources, referral by locality, etc., by reason. Though in these meetings, we identify any challenges, opportunities for improvement, manage any key actions to maximize referral rates, and manage delivery of any training programs. Continuously, we'll be assessing UCRT capacity versus current demand and anticipated demand. And we're hoping to recommence the ECS training with East to enhance identification of suitable fallers, but not just fallers, I guess it's all the other referrals that would fall under the UCRT umbrella. So further training and upskilling for our UCRT clinicians. So for example, things like wound closures, because that's something we don't do at the moment. And we'll be continuing with comms and good news stories and patient stories. And most recently, we are now working on the upcoming Cleric portal with a live date for sometime in November this year, and also remote access to the 999 stack. And with everything, we have to continue working on our data to improve the quality of our data and reporting so that we are showcasing accurate numbers, etc. So we move on to some of the work that we're doing with some of our tech providers in our localities. So we initially engaged with CareCall, who underprovide. So we reached out to CareCall just to look at, what are the referral opportunities, because part of the work we were doing with East, we received feedback that a lot of their referrals are coming from CareCall providers or CareTech providers. So we reached out, we had meetings with CareCall, and part of that meeting, they have now incorporated the UCRT pathway in their triage algorithm, which now link back to UCRT for minor injuries and falls pathway. And UCRT inclusion exclusion criteria is now linked in for anything else that may fall under the UCRT umbrella. And they've got direct access to the SPA, so their call handlers can ring directly to the SPA with a referral, and we normally would accept the referral and respond within 2 hours. So the clinical responsibility would sit with UCRT for any of those patients that are taken off their pathway earlier in their pathway. So that's an example of the CareCall's call algorithm. As you can see on the left, sits the inclusion exclusion criteria for UCRT, and this is their falls algorithm for calls. And you can see at the bottom there, you've got a disposition for UCRT for anything that is not life-threatening or falls. In terms of sustainability with our CareCall company, so we've got monthly improvement cycle meetings. We're continually working on data and evaluation. I think the feedback we got mainly from our CareCall colleagues was that a lot of their falls are happening outside of the UCRT operational hours. So either during the night, where perhaps patients are trying to mobilize to the toilet, or early morning when the carers come in and find them. So we're doing a lot of work to look at data, looking at potential demand. We're having early considerations for UCRT and discussion around what would it look like, what would demand look like if we were to extend our operational hours. So further development, further tech provider engagement. So far across the MSE, we've engaged with CareCall and Careline, who cover the thorough localities. So we still have some work to do in terms of engaging with our tech providers, but we have made a start. So we will continue to engage and reach out and raise awareness to see how we can support the patients and ultimately prevent patients going to A&E or dispatching an ambulance. So recently, in recognition of the work that we're doing in MSE, we had Luke East with the BBC, who heard all the great work we were doing around UCRT and the frailty virtual wards. And they visited us to film the UCRT, and we were showcased on the BBC News in July of this year. I'll just play a quick video. It's literally about 55 seconds.
incredible pressure is because of the sheer number of houses that are being built right across Essex, in Colchester and here in Chelmsford. The number of GPs just isn't keeping up with demands. And talking of demands, the extremely hot temperatures, I mean, the whole of the healthcare system is incredibly busy at the moment. And tomorrow I'll be focusing on the urgent community response team, who are effectively an A&E department out on the road. They help take some of the calls off the ambulance service, preventing people from going to hospital.
So we've just had a call from the paramedics. The lady's been on the floor for 4 hours. Carers have gone in and found her and obviously can't get her off the floor. So we're going in. We have a 2-hour response time where obviously the ambulances, they could be hours.
That's Licky's tomorrow night at 6:30.
So thank you for listening. Any questions, please put them in the chat. At the bottom of the last slide, we've got our animated video that we've been using to drum up awareness around what is UCRT and what do we offer the patients and colleagues and providers around our locality in the MSE. Thank you.
Okay, so my name is Jamie Frayne. I'm a paramedic, primary care paramedic, based in and around Chelmsford, working for a GP practice. Have been in primary care for a couple of years now, and I still work frontline with the ambulance service on a bank contract. So I think probably about 6-7 months ago, I was made aware of a patient that was on the floor for a considerable amount of time. Unfortunately, I found out about the patient the day later, so I couldn't assist. But this patient waited in excess of 11 hours for an ambulance to get them off the floor. And then I started thinking about my experiences in the ambulance service and also my experiences in primary care. And then came up with the question of, are elderly fallers the sole responsibility of the ambulance service? And I'd probably say pre-COVID, they probably were. As a paramedic on a frontline ambulance, I would go out to an awful lot of elderly patients that were on the floor and either get them up after assessment and leave them at home or take them into hospital for further assessment. But I think in today's NHS, we have to think a little bit more laterally. And that's when I came up with the idea of, in Mid and South Essex, we've got approximately 40 paramedics working in primary care. So they're paramedics who work for a GP practice. And I thought about thinking, how could we get these members of staff out in the community who are already out there doing home visits, helping with this rather big problem? So this project is quite early on. We haven't implemented it, but we are going through several stages to get it up and running by this winter. The vision is that we'd have a primary care paramedic who's notified about a patient on the floor in their community. The idea behind this is paramedics are very good at assessing patients in their community, and certainly very good at assessing patients who have fallen, because as we know, patients don't just fall. It could be for a medical reason, it could be for a mechanical fall that they've tripped over something. But equally, on the side of that, I thought, well, why don't we throw in a bit of continuity as well? So patient continuity, which I think is quite important. So the idea would be the paramedic who's attached to that patient's surgery attends them, assesses them. And after a full assessment, obviously the patient's then moved off the floor if appropriate. And obviously in brackets, I've written a couple, obviously not an exhaustive list of people who couldn't be moved. So for example, if you had a patient had very, very low blood pressure, you wouldn't want them sitting up, let alone standing. So depending on the outcome of the assessment by the primary care paramedic, I see it going to one or two ways. We could cancel the ambulance. The ambulance would then be, reduced demand on a ambulance service, which is already under a lot of pressure. And then we could go down the following community paths of, speaking to their GP, obviously speaking to our colleagues in UCRT, district nurses, frailty ward. There are so many options nowadays in the community, which is fantastic for that patient. But equally, we've spoken a lot about getting people off the floor and cancelling ambulances, but that patient might still need to go to hospital. They might still be unwell, which led to them having a fall. So it's not just about cancelling ambulances. It's not just about leaving that patient at home. It's about getting them off the floor and, in other words, stopping any extra harm coming their way. The other option is you get the person off the floor, you get them comfortable. You would contact the relevant ambulance service and hand over your assessment findings, which could, in essence, end up making that priority higher. So they would get an ambulance theoretically faster post-assessment. So we did a bit of number crunching. All this information is supplied by a great team, the Harm-Free Care team, based in Mid and South Essex. Now, interestingly, this is over 3 months. August, maybe don't take too much notice of because we're missing some data. But June and July, I think what's really interesting is blue is over 65s that required admission to hospital, and green is over 65s not requiring admission to hospital. So the reason I find this really interesting is green. Okay, so in June, 232 patients were taken to ED. They were assessed, but they weren't admitted. In my head, I'm thinking, well, that's an awfully big number. This is just for one hospital. In Mid and South Essex, we had 3 EDs. So this is just one hospital. So we've had 232 patients taken to hospital, assessed, and didn't require hospital admission. So in my head, I'm thinking, well, this is 232 patients that maybe we could have assessed on scene at home and then referred to the community. Also, like I said, the blue is people who required admission. So in June, going back to June, it's 208. Now, this isn't to say that 208 all needed admission. These could have been patients that ended up having a long lie and sustaining health conditions that needed them to go into hospital. And what I'm saying by that is if we got someone sooner, maybe we could have avoided those. There is another number that's really important, but it's not on the graph. It's ambulance call-outs that have gone to patients, assessed them, and left them at home. And the reason that's important is maybe we could have taken some of those calls off the ambulance service, again, increasing the amount of ambulances that would be out in the community responding to sicker patients. So the benefits, I think we've heard, and I'm sure we can all figure out a lot of the benefits, but a lot of patients enjoy or need to be treated at home. So I see more patients being treated at home. Again, going back to the ambulance service, but reduced demand on an ever increasingly busy ambulance service. We haven't gone into the winter yet. With the energy crisis, are we going to come across more elderly people not heating their homes? Patients off the floor faster. That's good for everyone. That's good for the patient. It's good for the NHS as a whole. This will reduce ED attendances. And more importantly, we're reducing patient harm. So if we're getting them off the floor faster, they're not getting pressure sores, etc. And like I alluded to earlier, continuity of care. So hopefully we would have a member of staff from their practice who assesses them. All the assessment findings would be found and written on that patient's notes, and we'd have continuity of care. Obviously, there are limitations. So one of the big limitations I see is primary care paramedics availability. So we have a high daily patient workload. So for example, I have a minor illness clinic where I see 12 patients in the morning, and then I do home visits in the afternoon, which is approximately 5. So I'm seeing about 17 patients a day. We're essentially asking paramedics to fit in potentially another patient at least into that high workload, and we need to find a way out or a way around that. Patient monitoring. Typically, primary care paramedics have limited monitoring, and what I'm getting to is a 12-lead ECG. So, for example, what we call a collapse query call, so we don't know the reason why that person's ended up on the floor. We would need to do a full cardiac assessment. It'd be a crying shame to get that person off the floor, but still need a paramedic and ambulance to attend to do an ECG. So we're also looking at that side of things as well. Some of the GPs have spoken to are apprehensive, and I can understand why. It's never been a part of the primary care workload or priorities. But, you know, the NHS is under considerable pressure. And I think, like I say, I think we need to start thinking a bit outside the box now, especially as we've got lots and lots of paramedics in the community. I've asked for volunteers, so paramedics, to volunteer for this project. At the moment, I've got low numbers. I think out of 40, I've probably got about 10 now. Ideally, I wanted all of them, but I think there's some hesitancy due to, obviously, they already have busy working days, and they see it as a problem of fitting it into their working days. So we're working around that. And obviously, it goes without saying, funding. A lot of the equipment we need is quite pricey, but I think it's an investment. You know, for example, buying a 12-lead monitor wouldn't just be used for a patient on the floor. It could be used as a defib in the community. It could be used for every other patient that we go to in primary care. So thank you very much for listening. I've left my email there. I just hand you back to the team.
Really interesting content that's come through. And what I love is the different approaches that are being tried, and nobody's there and got a perfect model yet, but it's a journey we're all working on. And whatever we do with a holistic approach to this, it's going to have a massive impact both on the system, but most importantly on the residents within these areas. So I'm very conscious of time. I think we've got supposedly 4 minutes left. Now, as I said at the beginning, we may well run over, so we're going to be sending a recording round. We may not get through all the questions even. We'll try and go through as many as we can, but if you've asked a question, hasn't been answered, we'll try and put you in touch with somebody that you can catch up with offline. So a lot of this has been around the razor chair. Now, I know this webinar is about the effectively the approach, but somewhat of the enabler is the ability to lift somebody off the floor. So my colleague, Andrew, is going to be having a fall behind us, and I'll just do like a 30-second, maybe slightly longer than that, demonstration of the razor chair. So he's had a very graceful fall, admittedly, but I trust you can see him. Yeah, I think that's going to work okay. So for those that haven't come across the razor chair before, it's a lifting device that comes in 2 packages. You've got the backpack here, and then you've got the seat unit here. So we're going to work on the assumption that Andrew is safe to lift, and I'll just demonstrate simply how the chair works. Take the seat cover off. Right, so the first thing we're going to do is just ask to lift his legs like so. This has created an area underneath where we can slide the razor chair. Like so. So roughly central, thumb up against the thighs. And then in the backpack, you have got the other components. So it comes out in the order in which you need them. You can't assemble it incorrectly. So you've got 2 of these backrests and then 4 of these lifting arms. So I'll go around and assemble the razor chair so you can see effectively how it operates. If I do it from this side, you might be able to see slightly better. Right, so we're just going to typically ask the fallen person to just cross their arms like so. Conveniently already done that. Just grab this lifting arm. Okay, sorry. 1 foot this side of the sit unit. I'll just roll Andrew away from me slightly. Pop the backrest in. And then maybe working on the assumption that opposite me there's a bath or something. Something that's going to prohibit me from going around the other side. I'll just demonstrate it from use of one side. So just roll towards us, pop that in. And so the hard bit has effectively been done. Got the backrest underneath. Got the seatbelt, mainly for reassurance, but can be slid up and down dependent whether the resident needs more upper body support. So then these 4 lifting arms will pop in. Each time we're doing it, we've got a notification noise to say that it's been assembled correctly. And then when we put this last one in, it makes a slightly different noise, which indicates we're safe to lift. Got a remote control in the seat of the unit, and it's just simply a case of reassuring the fallen person, supporting their head, like so, and then we'll just press and hold the up arrow, like so. So as you can see, there really is only one of me using this razor chair. It can be used by one person. Obviously, if the client was to start deteriorating, you can stop at any point, lower them back down. It may even be wise to stop at this point just to sort of double check they've got their bearings and they're happy for you to carry on. Working on the assumption that Andrew's still okay, I'll keep going. And you'll see that it will come into more of a perching position. Dependent on the height of the person, you might not be able to go the full way, dictated by what point their feet come off the ground probably. And then we can just undo the seatbelt, and then maybe with the aid of like a Sarah Steady or a walking frame, Andrew can then mobilise off the chair, and the ordeal in terms of lifting them is over with. So that's a demonstration of the razor chair real quick. I just want to move on now to the questions and answers. I'm going to first go through the ones, or at least some of the ones that are shown in the question and answer section. If those on the panel maybe just want to turn their cameras on in readiness to support with some of the answers, that would be great. And then I'll just try and field them out to the relevant people, dependent on who it kind of fits best with. If we pick up on this one here first, and maybe this is one for you, Michelle or Angela. How did you reach the decision to use the razor chair compared to other lifting devices? And what were the preferences? I think, Michelle, you probably know on that one.
Yeah, so we have piloted more than the razor chairs. We have piloted different chairs with the OT support around what went into the acute wards. We decided to increase the number of razor chairs that we were going to pilot, but we did have 20 of another chair that we were piloting at the same time. And the feedback from carers, where they'd had the opportunity to use both, was that they preferred the razor chair just for ease of use. Storage, it takes up very little room. So I think that's basically why we decided to upscale that one. There is a manual version of the chair, but again, feedback from carers around the fact you still have to manually operate that, which would be a physical thing on their backs as well, was that we continued to purchase the electric razor chair.
Okay. That's good. Then question here from Tina Janssen, which I did notice somebody may have answered in the chat about there being a lot of questions about no lift policies in care homes, and care homes feeling like they're acting outside of their policy by implementing the use of the razor chair. How have these questions been addressed? I don't know if anyone on the panel wants to answer that.
I think just to add that any home that had got a razor chair signed an MOU, so they had to have that signed off with, if it's a care home group, it always has to be signed off by that care home owner or company. So we have got some care homes that currently have no lifting policies, and they don't have the razor chair, but those that have embraced it, you can start to see the feedback that we're getting.
And it's a real interesting point I see there from Daniel Hiscock in terms of care homes cannot have a no lifting policy. I think what we are all dealing with, aren't we, is we've kind of managed to create a real risk averse culture in terms of everybody wanting to make sure they're not effectively going to be getting themselves in the soup in terms of how they respond. I think we are on a journey that is moving us more to what's the best outcome, what's the best intervention for our person on the floor. 9 times out of 10, they're going to be better not on the floor than left on the floor. Now, I appreciate that's, I am only quoting from like-minded individuals from the healthcare space rather than just myself. But right, let's pick up some more questions.
I think a lot were more requests around sharing of data and, engagement rather than questions.
Fine, okay.
There is one about the weight limit, Grant.
Oh yes, on the razor chair. Yep. So the weight limit of the razor chair is 150 kg, which is just shy of 24 stone. Pretty much equivalent to the majority of mobile hoists that care homes would have. The other thing I just wanted to point out in terms of there's a lot of questions around the post-falls response and checking whether somebody's safe to lift. So kind of as a side from the project that's been happening with Mid and South Essex, there's been a lot of work we've been doing in terms of developing a post-falls decision support tool. So this is designed for non-clinicians to be able to assess whether somebody's safe to lift or not. And the thought process is it's trying to move us away from this risk-averse culture that we've got where calling 999 is effectively the easiest thing. So the care staff would effectively go through a checklist which will categorize the fall into a major injury, a minor injury, and then a no injury. And the idea behind it, and obviously happy to share more details in due course, is that it kind of models the way the NHS is moving in terms of the urgent community response, the 111, so that we've actually got these fallen people being signposted to the correct services rather than just the tendency to call 999. Ruben will collate the slides and any relevant handouts that need to go round, and everybody that's registered will get that. And then if anybody's got any questions for the panelists, just reply to the email and we can put you in touch with those that have spoken. But in terms of the webinar for today, I do believe we come to the end. And I think I'd like to, on behalf of everybody else, thank everybody from Mid and South Essex that have given up their time to present the fantastic work that you're doing. But with that, the recording hopefully should be with you either this afternoon or this week at least, and we'll be in touch.